Now, this is not just my party, everybody, okay? This is also your party, because tonight we're gonna have an EKG bonanza where I get to share with you some tips and tricks to make your EKG life easier. And I'm super excited about that. So if you're new to our group, welcome in, officially welcome in. I will be your hostess of the evening. My name is Jen Carlquist, and just a little background on me in case you haven't met me. I am a physician assistant and I work in the emergency room and in a cardiology office. I've been a PA for 14 years now and prior paramedic of 13 years. And what I want to share with you tonight are some tips and tricks that I've learned along the way that will make your life easier. Now, my goal is to keep this short and keep this sweet, because I know that we are about to roll into New Year's Eve tomorrow night, and then we are going to party like crazy, right? And have an amazing time. So Zach says, I'm wearing your zebra friend. Zach, that's so awesome. I wish I could see you. That makes me happy. And welcome in everybody who's joining us on Facebook. Thank you, David. David's in the house. What's up, David? I sure miss you. I'm so excited to get this party started again. I've really missed everybody. Lacey, thank you so much for the happy birthday. Hello, Brind. What's going on? So thank you, Megan. Welcome in. I'm so happy that you're here. You guys showing up, Daisy, my girl, showing up to celebrate my birthday with me is really like the biggest gift. You guys have no idea. I'm super honored. So I have some cupcakes that we'll be eating at the end. You guys can decide if we eat chocolate or vanilla, okay? And in the meantime, I just want to kind of also whet your appetite for what's coming next week as well, right? I want to give you a little hint. Thank you, Patty. Hello, Kathy. So nice to see you guys. I want to give you a little hint of what's coming. David's been looking for those EKGs. Don't worry, David. I'm gonna bring some good ones for you, David, especially next week. So we are going to do a 5-day EKG challenge next week. Now, this is a little appetizer to that. This is a little snack, so to speak, a little mini cupcake like I have next to me. And before we get started with the 5-day challenge, this is going to be a little focused, really get good quick so that you can go into the clinic as of tomorrow and start putting in actionable steps that you can use as of tomorrow to start saving lives. Michelle's wearing her heart t-shirt. What's up, Michelle? So nice to see everybody. Okay, so, I think one of each, Angela says. Okay, that's not bad. I can do one of each, Angela. I like it. So another little surprise for you guys. I know I kind of hinted at it, but I want to tell you the details. We are going to be giving away a virtual ticket tonight. We're giving away a virtual ticket for free to our May live in-person Monterey conference. So excited about that, because I'm going to get to have some of you in my hometown with me in May on the 22nd. And so some of you are going to be live, and we're going to be giving away one ticket tonight to that 8-hour in-person intensive hands-on where we are hiring professional studio to be streaming. So that's the ticket we're going to give away at the end of the night as the present to you guys. Zach says, so incredible. I know, I'm so excited. Hey, Melissa, what's up, girl? Thank you, Sarah. I'm glad you're here. What's up, ladies? So that's the prize. How to win. Let me tell you about that. At the end, I'll be telling you a hashtag that you can put in this feed, right? And I'll be choosing from the hashtags. We'll be doing the drawing like we always do in typical 5-day format. And I'll be announcing the winner on a separate live when we're done. So I'm super excited to be giving away a ticket to the live conference May 22nd, where you're going to get to meet Sean, Coach Sean. You're going to meet Coach Michelle. Coach Megan is flying out. Coach Samantha's coming out. Coach Asbury is coming out. And of course, I will be there. And so it will be a huge, huge, huge session with breakout sessions as well that will be streamed to our live stream folks as well. So that's what the ticket's going to be. Hello, Susanna. Yes, I'm having a great birthday because I'm here with you guys. So just a little flashback really quick. Okay. So even though I hold these challenges for you guys, even though I hold these classes, I always hold near and dear to my heart where I came from. And I try to stay really, really clear on how I got here so that I can bring you guys all with me so that you also feel comfortable with EKGs. Okay, so this is a picture of me back in, I don't even know what year, honestly. I was like 21, I think. And I was on the fire department, volunteer, and I was a paramedic. And I remember being so terrified of EKGs. And it is this fear that sent me on the path that I have gone on now to get good. And so when I looked back at how I got here, okay, when I looked back, I put together some, thank you, Carrie, thank you. I put together some action steps and some things that I realized were important and things were not important. And one of the things that I've noticed that I focused a lot on, mostly because the teachers made me, right? And maybe this happened to you. Hey, Carissa, what's up, girly? Hi, Tori. Again, welcome in. Oh my gosh, so excited to see you guys. I focused on and I got stuck in the weeds. Now, what I mean by the weeds is I got stuck on things like I need to understand vectors and axes and all the things that weren't as important as the life-threatening things. Okay, so that's what we're going to focus on tonight. We're going to focus on some life-threatening important things, and we're going to scrape away all the unnecessary stuff that may have tripped us up in the past. Okay, hi Lisa. So who is this going to be good for? Anyone who reads EKGs, and I'm assuming if you're here, that is you. And you know, just to remind you that, like me, when I was back there in that picture, right, I had these pie in the sky dreams of saving lives, and literally every single day, that's what still gets me up in the morning, and then teaching you how to save lives, right? And I know that's why you're here. I know that's why you're here on a Thursday night. Some of you are on the East Coast, it's late, and you're here because you also have these same dreams. Okay, and so that's why we're here. But we're here to take some notes, write down some really, really good tricks that are easy to put into place as of tomorrow. And so let's just get down to it. Okay, let's just jump right on in. Okay, so tip number one, I'm going to share with you 5 of them tonight. Okay, tip number 1 is to focus on the intervals. Now, if you don't know what those are, I'm going to show you what they are in a second. But I'm also going to tell you that when I was first learning this, when I was first learning EKGs, I was taught that, oh, those numbers, okay, at the top of the EKG, those are for the cardiologist. You don't need those numbers, honey. And I was like, okay, that's reasonable. Now I was learning this as a paramedic, so I didn't question it. I was like, okay, those numbers are not important. I don't know why they're there, but that's cool, right? And so flash forward, yes, tip number 1, Tori's saying know your intervals, right? This is so important because there's a lot of clues that live in there for us. And there's clues in the PR interval that are helpful, and there's clues in the QT interval that are helpful. And then knowing the normals is super helpful. It's also important to know when we can trust the machine read and when we can't, okay? And the shocking fact, and this I know to be true, and I see this every day, and I'm going to show you an example of this, 2 examples very shortly, that the machine software interpretation, the thing I used to use and rely on like a crutch, actually can lead us astray as much as 42% of the time. It can be inaccurate. So we're making these like critical life-threatening decisions based on bad data, right? And if you don't do that in the other part of your practice, for example, I'm big on don't make blood pressure decisions based on one blood pressure or on a patient's machine that may be wrong, right? Like, let's not make decisions on bad data, okay? Make decisions on good data. So knowing that this is faulty, we're not going to believe the machine software. What we can trust though, okay, what we can trust is knowing the correct numbers that these should be. And we're going to go through that really quick. But let me just give you a caveat before I lay this out for you, okay? The caveat number one, and David White, this is a big line of David's, and you'll hear him say this a lot. Oh, David says it's much higher than 42%. Susanna says never trust the machine. I totally agree. Hey, Jessica, what's up, girly? Hey, Valerie. So the thing David said is that you believe the machine software about as much as you believe, or no, you trust the machine software interpretation as much as you trust gas station sushi. So if you've also been tricked by the machine, what I want you to do, just so I can see how many people have had this happen, put #sushi in the feed, okay? Whether you're on Zoom or you're on Facebook, but #sushi if it has also given you bogus info, and you will start to see how many people are in the same boat, right? They've been duped by the machine, right? Definitely. So a lot of us have. You're not alone. And I want you to take a look at these comments that are coming through and realize you're not alone, right? And I've also been there. But knowing that if you have artifact, you can't trust the calculations, knowing that you can kind of take that with a grain of salt, right? So don't trust the machine read and do your own calculation of the intervals. And there's a little tip I have to show you, a little trick that I use in the clinic. I actually manually check my intervals with a tool like this, or even with just looking at the boxes. Okay, many of you have these already. These are the RCAT windows or the badges. You can use these red lines to look at the intervals. Okay, we're going to be giving away one of these tonight, by the way. So someone lucky will get this, and some lucky person will get one of the tickets. But you can also do it by hand. And so if you have a lot of artifact, or if you have something that's really fast or really slow, you should probably calculate it yourself. So these numbers are as good as, right, if there's no artifact and if there's nothing else major going on. But as a whole, they're usually right. So that's my blanket statement. Okay, hashtag sushi Lucy, age undetermined, very helpful. I agree, David. Yeah, so lots of folks, sushi, Nicole, Lacey says very deceiving. Natasha says sushi. Yeah, a lot of people. See, so you're not alone. So let's talk about what the normal ranges are so that we know how to read these. Because here's the thing. I know that there's a lot of things to remember in medicine. I know that, and I feel that struggle too every day. So there's a couple of things that I just don't lock in to my memory, right? Some things I have in my peripheral brain, my cell phone, and maybe you have something written down on your badge, whatever you use as your peripheral brain, okay? But you can write these intervals down so you can reference them later and look back on them until you know them pretty solidly. And here's what I think is the real highway robbery of the whole thing, okay? So you've got these numbers here that print out on the EKG, and they don't give you the normal ranges right next to the data. They just expect you to know it. So I've laid them out right here for you, and I'll go through them in a minute. But if you think about lab values, they give you a number and they give you that reference range right next to it, so you know what the normal is, okay? But the machine doesn't do that. So David has a really great suggestion. I do the same thing. David and I are like two peas in a pod. We think alike. He says, take a screenshot, start an ECG gallery in your phone. And I totally agree that I do the same thing. David actually got a couple EKGs from me yesterday as a present, right? Because I had such cool ones come in, and I'm so excited to share them with you. But going back to this, the numbers, let's talk about that. So what's the first number? Ventricular rate, 84. Is that normal? Well, let's take a look, right? 60 to 100 is normal. And that's also what the heart rate is. So yes, that is normal, okay? The next number down is the PR interval. That should be between 120 and 200. And it is, it's 150. So good, okay? Let me just take a little pause here. Why are we doing this in the first place? Like, why does this even matter? Well, as it turns out, there is a condition you can diagnose if there is a short PR interval. So if you know what that is, if you know the answer to that, put the answer in the chat. Melissa Mainville says she loves the RCAT window. Lots of folks are saying sushi on Zoom. So as I'm moving along, you guys can type it in the chat on Zoom and on Facebook what you think that answer is for a short PR interval. What disease process does that give us a clue of? And then we'll keep going. QRS duration, okay? Less than 120. Okay, we got some answers. We got a WPW from Doreen, which is absolutely spot on. Samantha, so I just want to point out the people who answered first are two paramedics. Strong work. Yes, I love it. Oh, yes, so we're having some questions, left or right axis from Ginger. Ginger, good question. I'm not going to cover that in this talk, but I am going to cover what normal axis is really quickly for you guys, and everybody's nailing it. Yep, David says he's got Wolf on his mind, and everybody, all the other folks, Angela, Melissa, Brind, and Heidi are saying Wolf Parkinson's White, and you guys are right. So take home tip number one, if you have a short PR interval, okay, you have a short PR, you got to think about Wolf Parkinson's White. If you have a long PR, tell me what disease process you might think about. Yeah, Christopher, nice, good. Lacey, totally spot on. Okay, so Zach's gonna switch to Facebook. That's totally good. So QRS duration, okay? QRS duration, we're gonna move to that. Tell me this, what amount of boxes, how many small boxes is a QRS that's too wide? Over how many small boxes? Okay, type that in the chat. Samantha says first degree block, good. So a PR over 200, we have to think about first degree block. So now we've got two clues. A short PR, we're worried about Wolf Parkinson's White. A long PR, we're worried about a first degree block, right? Or any block for that matter, as Heidi and Lucy are pointing out. So strong work, ladies, all of you guys. And it's over 3 small boxes that a QRS, if it's over 3, that you guys are putting in here, it's concerning, okay? So over 120 milliseconds, which is right here, is concerning. That might mean a block, that might mean a bundle branch block, it might mean hyperkalemia. There's a lot of things it can mean, but we just need to know for tonight what normal is. So less than 120 or less than 3 small boxes. This is 76, so this is spot on, okay? Now, and David says, think about a 3rd degree. Melissa says 0.200. Nice job, you guys, okay? Now, the QTC is the next one down. I want you to just for a second in your mind, okay? I want you to, every time you see an EKG, I just want you to like forget about this. You don't need this. You just need the QTC, okay? This number here, the QTC, which corresponds to here, that's the only number we need. The QT is uncorrected, right? We don't need that because it's not good data. The corrected one is the only one we need. So this number should be less than 460, okay? Less than 460. It is, so we are normal, right? It is, so we are normal. And then, okay, another good point by Samantha. There is a difference, okay? So if you want to split hairs, and some people do, if you want to know the actual textbook, 450 for men and up is prolonged, and 460 and up in women is prolonged, okay? So if you just want to remember 460, that's totally okay too, because that makes it easy, and then you just have one number to remember, okay? And it's not going to make that much of a difference what you're going to do between 450 and 460 anyway. And then the last number we need is the axis, okay? So Ginger, I know you were kind of wondering about axis, but I'm just going to tell you the normals really quick. Right here, 51, that is the number that you're going to use. Now that lines up to the R axis. That should be between 0 and 90. 0 and 90 is normal axis. And honestly, axis in the grand scheme of things doesn't really matter unless you're doing critical care medicine or you're on the ambulance. If you're in family practice or in the clinic, axis is only really super helpful if you have potentially a pulmonary embolism or a couple other times. But in general, we don't really make a whole lot of decisions based on the axis, at least in primary or urgent care or ER or wherever you're practicing, unless you're on the ambulance. Because if you have a wide complex tachycardia, it could make a difference, okay? But that's not what we're talking about tonight. We're just talking about normals, right? And that's it, okay? So let's talk about looking at a real EKG now that we've looked at the intervals. Let's do that together. And David's making a really good point about the short QTC. If it's less than 425, it's very unlikely to be a STEMI. So if you watch David's comments in the feed, he drops pearls all night long. Like, they're just amazing. Okay, so let's look at an actual EKG. We just remembered from the last slide that 460 is too long, right? Anything over 460. And if you're looking at the QTC, which is right here, QTC, right here, it's 713. So that's too long. That's too long, right? Oh my gosh, what are we gonna do? Should we send the patient to the emergency room? Should we, like, I mean, obviously we're not gonna give them Zofran, right? But here's what the real answer is. What is on this EKG that is potentially making this an incorrect calculation? What is on this EKG that's making it incorrect? And while you guys are sorting that out, I'm gonna give you a visual trick, okay? I'm gonna give you a trick. If you ever are suspicious that maybe that number is not right, okay, you're like, yeah, I don't really think that's right. What you can do is you can go over to your R to R interval and then cut it in half, right? So if that's the R to R, you're cutting it in half. If your T wave is before that, which this is, then it's not over 500, okay? So you guys are nailing it, okay? You can use your tool, you can use a pen, whatever you want, but measure it yourself. This is actually faking you out because, and you guys caught it on Zoom, Carrie says artifact, and Charity and everybody else says artifact. So good job, you guys. Now we repeat it, right? Like David said, repeat it. It's incorrect. So let's do repeat it, right? Here it is. Here's the repeat. And check it out. So as you can see, there's no artifact now, which is really super cool. It's a clean tracing. And you can see now that it's 444. And that's right where it was before. And here's the T wave. And right, it's not halfway between. So isn't that super helpful? So already we've gotten a lot of pearls out of today. If there's artifact, we don't take the EKG, we redo it. And honestly, I know that it's hard sometimes to ask for another EKG, that you seem like you're being, needy or picky or what have you, but it's not. It's totally okay. Katrina, how do I get to Facebook Live? You can go to our Facebook group, Katrina. It's the 5-day EKG challenge, January, and you can see all the comments that way. You just go in there and just refresh the feed and you'll see all the comments come through. Tori is sending you a link. Thank you, Tori. I really appreciate that. Okay, so anyway, yes, this was right, 444, right? It's totally fine, and we don't have to panic. So this is the value. Okay, so the next number 2 hack of the evening is when to worry about the EKG. Now, clearly this is a long conversation, right? Because there's no way we could teach you everything tonight about when to worry, but I know that from reading your entry questions into our group and interacting with you guys several months now, I know that this is the most pressing thing on your mind. I know this keeps you up at night. I know that every time an EKG is handed to you, you get that pit in your stomach. Not everybody does, but I know a lot of you do, okay? And I know you're like, oh, how much do I worry? There's some flip T waves, how much do I worry? So let's talk a little bit about that tonight, okay? So let's just pretend for a second. Let's take ourselves and let's put ourselves into the setting where we work. And let's pretend that this EKG comes into wherever you work and you get this EKG. I don't want you guys to put it in the chat unless you feel super confident, right? But think to yourself, this is a little practice, right? Think to yourself, what would I do with this EKG? Okay, now we're going to be talking about a way to approach the EKG next week when we do our 5-day EKG challenge on night 1. We're going to talk about the 10-step approach. So definitely don't miss night 1, which is Monday. But in the meantime, take what you know about EKGs now and actually really think through, what would you do? So I have some folks, okay, so we have a lot of folks in here who are seeing. David says, was there syncope? Yes, there was syncope, right? Yeah, okay, so Ginger and Samantha Ginger says, I see ski slopes. Samantha says she thinks she sees brigadas, okay? Daisy says, check the patient, check the history. That's always a good idea, Daisy. Those are words of wisdom. So David says the computer is wrong, okay? So I'm sure David would tell us his thoughts on the CKG, but at the end of the day, what we do have just standing out really clear to us is there is an incomplete right bundle branch block. We're gonna talk about this more next week, okay, this actual thing. But, okay, there's a couple other things wrong, right? There is something standing out very clearly to a couple of our folks already. They said there's ski slopes. Okay, the ski slopes are here that Ginger and Samantha saw. Okay, they said, hey, that doesn't look right. And our first step of our EKG interpretation that we're going to be learning is looking for big sick, little sick. I'll talk about this more next week. But in general, what does that mean? It means, is this EKG really bad or can we wait, right? Because that's always the question you have to answer, especially if you're in family or like, okay, do I have to send them to the ER or can I refer to cardiology? And you know, right, that cardiology, there's a wait of like 2 to 3 weeks unless you have some sort of pull. And it's a stressful 2 to 3 weeks because you're like, oh my gosh, I'm rolling the dice. I hope I made the right decision. I hope it's okay. Have you guys ever been there? Like, have you just been like so stressed? So this is, yes, this is a can't wait for next week. Tori says, yes. Oh, hey, Z, you're back. So this is indeed, okay, I totally agree with you. This is indeed somebody who cannot wait till next week, okay? This person, as you guys already correctly called out, has something called brugadas, okay? Now, we'll talk about this more next week. It's a life-threatening thing. Coming in like a wrecking ball, David says, yeah, you're gonna go to the ER with this one because this patient has a high risk of sudden cardiac arrest. This is one of the things we look for in young people, especially in the setting of syncope. Okay, so if you ever have a syncopal patient, this one thing should be on your checklist, like absolutely every time, okay? And it's a ski slope ST elevation in V1 and V2, and there's no reciprocal changes. The machine will often flag this as incomplete right bundle, and this should be a clue to go back and look for this if it ever says that, right bundle or incomplete, you go back and look for this. Okay, now, where on the CKG, hashtag sushi, where does it say Brugada's on here anywhere? It doesn't, right? And that's troubling because here you have this life-threatening thing and the machine is not saying there's Brugada's anywhere. And so if you don't know this finding, you let the patient go home and you're like, oh, right bundle. I'll just, send them to cardiology. They can sort it out because I know incomplete right bundles are not life-threatening. They're not a today thing unless they're a Brugada, right? So this is why we don't just trust the machine read. This is why we train you in the 5-day as a step, like a first step in our training, right? We teach you to look for these high risk things so that you don't get burned, so that you don't get sued, and your patient doesn't die, and you both go on and have a good day. And your doc that you're working with doesn't look at you and say, we have to talk. Because those are the worst words absolutely you can hear. So this is one of the high risk patterns, right, that we're always going to look for Brugadas, okay? Channelopathy, and as David just pointed out correctly, syncope, near syncope, especially in a young person, you look for this. But always, always, if you have syncope, you look for this. It doesn't matter how old they are. David's right, though. You usually don't make it through your life with this, okay? If you're young, we usually get a hold of you, fix it, or you die. You usually don't make it into your older years, right? But now you're going to know, okay, cool. Check. Thing number 4, valuable Jenna said tonight, check for Brugadas. Okay, so like write that one down. That's what you're writing down in your notepad. V1, V2, ski slope, ST elevation. PS, we'll be covering this next week again, but don't worry. And David will probably be on with me and he'll give his 2 cents, which are always really, really great. This is another EKG that I just wanted to really quickly show you of another time where something also was very wrong. And if you don't know what those findings are, then you could potentially have sent this patient home, okay? So I just wanna kind of test the waters here, and I just wanna see what you guys think, okay? This is our last one where I'll kind of put you on the, well, no, that's not true. I'll put you on the spot again. It's fun for me, I like it. But don't feel pressured to answer, right? This is a game you can play if you wanna play, don't have to play. But if this was really an EKG that you were interacting with, and I'm just gonna tell you really quickly, this patient had chest pain for 5 days. This was a patient that I saw in the cardiology office, and their chest pain wasn't getting better with nitro. So that means one of 3 things. Not getting better with nitro. So tell me what those 3 things could be. Let's just sort that out together. Like, what are the 3 things if the nitro's not working? What are the 3 possible? Well, there's more than 3, but just let's talk about 3. So Davey says ischemia. Totally agree. Daisy, yes, ischemia is one of the big ones. What are some other reasons? And you medics in the house, you should be chiming in. What's another reason that the nitro might not be working? The patient maybe left the nitro. Oh, Daisy says MI, totally agree. Another reason that the nitro may not be working is because it may not be fresh. It may not be fresh nitro, right? It may be expired. Or they could have a PE, right? Or they could potentially be having a aneurysm, dissecting aneurysm, right? So any of those things are possible. Hello, Mindy Lynn, how are you? And David says it might not be ACS, right? Those are all things to think about. But in this particular case, Daisy, you hit the nail on the head. There was some ischemia there, okay? And I'm just gonna tell you really quickly that I had a decision to make because this patient didn't want to go to the ER. For 4 days, had been calling cardiology, and they said every time, go to the emergency room. He didn't go. This guy really did not want to go. And you have patients like this every day. And I know if you're working urgent care, they come to see you there. They come to see you in family. And if you have to make that decision, what are you going to do? What would you guys do based on the CKG? And the options are, but David's, if you listen to David, you're going to be right, right? The options are send the patient to the emergency room, even though he doesn't want to go. Option number 2 is refer to cardiology and do an urgent referral, like a stat referral, and hope that they get in soon. Or option number 3, go home, tell the patient to take some Tums. They probably have indigestion. Option number 4, send them some nitroglycerin, some fresh nitro to the pharmacy and hope that works. Okay, so I'm going to tell you that the right answer And the answer that I did with this patient was I took him to the emergency room. 5 minutes after, because we're right across the street, I took him to the ER. 5 minutes later, yes, the clue is in the T wave, David. They declared him a STEMI overhead. 5 minutes after he got there. What was the clue? What was the clue? Okay, so this is a patient that when you ask yourself how much to worry about the EKG, I'm gonna fill you in on something, okay? Fill you in. There's a little saying right here that is not sushi that scares me more than anything on the EKG. ST T wave abnormality, okay? This is the scary thing, okay? So Samantha says, see if you have reciprocal changes. I agree, Samantha, always, always. And Ginger says inverted T waves. Ginger, yes, good thinking, Ginger. So let's stamp out for you guys the T waves that are inverted. So right here, those T waves are inverted. We're going to talk about this on night 1 of the 5-day, right? What T waves should be pointing which way. But just know that if you don't know this, if the T waves are inverted and symmetric like this, rule number 1, T waves should never be symmetric. Rule number 2, they shouldn't be upside down in V5 and V6. That alone is a problem, okay? That alone is a problem. And also, Melissa, who I believe is in cardiology, Melissa, you smart girl, she says she sees some ST elevation in V2 and V3, but the really big take home that she's seeing is hyperacute T waves, okay? Hyperacute T waves, yes, okay? There's a couple other things going on in the EKG, but the money really is happening here and honestly right here and honestly here. Okay, so we're going to talk about this more on night 1, don't worry. But the other rule number 2 about T waves. So rule number 1 was that they shouldn't be inverted and symmetric. Okay, and rule number 2, the T waves are the baby of the family. They shouldn't be as tall as their dad. They shouldn't be as tall as their dad. So that was, those 2 things combined were the clues that this patient was going to have a STEMI. And I'm so glad I luckily knew this, okay? But if you don't know things like this, if you don't know when to worry about the EKG, and you can be stuck in a really bad position. So glad you guys showed up. So now you know T waves shouldn't be symmetric and inverted, except for AVR and V1, they can be upside down. But we'll be covering this, don't worry, next week, okay? So take home, if you see this ST T wave abnormality, go look hard at your T waves and scrutinize the heck out of them. Scrutinize the heck out of them, okay? So number 3 is don't ignore the voltage. I just want to take a second and talk about voltage for a second. So voltage means the amount of electricity that is being generated by the muscle of the heart that is being transmitted to the chest. So how big your R waves are or how small they are, that's voltage. And you don't want them too big. You don't want them too small. I kind of feel like voltage is a little like Goldilocks porridge. Like, remember the bears that came to eat the porridge, and someone came to eat the porridge. I don't know, I think it was the bears. And they were like, no, this one's too cold. This one's, not hard enough. This one's too hot. Like, none of the porridges were right, right? So it's kind of the same situation. So, and correct me on this, child's rhyme that I'm talking about if I'm wrong about the porridge, but something about the porridge, it's the same thing. Like, you need the voltage to be just the right size, and you always have to be sensitive to that. Here's why. And R wave progression 2, Daisy, yes, Daisy is so smart. The reason why we need to know this is because if you have really low voltage, that can mean something life-threatening. Usually really high doesn't mean do something right now, but really low can. Okay, that's a clue. Let's talk about a case real quick. Okay, let's talk about a case. So a 45-year-old female, this is a real case, okay, and I'm going to show you the real EKG and muscle mass, Daisy says. So we're going to talk about this. And David said it was an LAD occlusion. David, you're right. You're so right. So this patient was a 45-year-old female. She had shortness of breath with exertion for 1 month. So when you have a 45-year-old female who's got dyspnea on exertion for 1 month, you need to ask the follow-up question, like, what can you not do now that you could do a month ago? Like, quantify it for me. So she says, well, I could ride my bike really fast a month ago, and now I can barely walk across the hall. How worried are you? Without even seeing the EKG, how worried are you? Please say very worried. Please say very worried, okay? All right, now, you do some labs. And you're thinking like, okay, maybe she's a menstruating female. Okay, Daisy, I love where you're going with that. She says anemia, tachycardia. I love that, sister. Okay, thank you. But she's not anemic, right? You're thinking about kidney function, it's fine. Creatinine's 1. And if you're in pre-hospital, you don't need to know these numbers because you won't be using them, right? But you think about, things like mixed edema or things like that nature, but the thyroid's normal, so probably not. Daisy's thinking about PE. Daisy, you go girl. You go girl. I love it. Yes, you should be thinking about PE for 100%. Absolutely. Okay. So we'd be looking for tachycardia, like you were thinking. And the glucose 113, not fasting. So honestly, we don't care. Right now, ESR, CRP normal. Now, here is the money. This is so helpful. They had a calcium score on her from 4 years prior, which was normal. Calcium score, in case you don't know what it is, it's a CAT scan of the heart. And you're looking for any calcification, because when you see calcification in the coronary arteries, you know by default that there's most likely soft plaque around it. Therefore, if she has 0 calcification, she probably has 0 plaque, making an MI very unlikely. So Daisy says CHF, cardiomyopathy, D-dimer, Crystal says D-dimer, and David says 35 and up, any complaint from the waist up, get a 12 lead. And that is definitely a good piece of advice. So here's your EKG, okay? And tell me your thoughts, okay? And if this patient came to you in the clinic, let's just say you work clinic, right? Okay, or maybe you work ambulance, the patient wants to AMA. If you work ambulance, the patient wants to AMA, what are you gonna tell her? If you work in the clinic, okay, Daisy says drug abuse, cocaine, good thought. Daisy, I like where you're going with that, girl. So tell me what you think, okay? Tell me what you think, and what do we do? Okay, so Daisy says she's Brady, but we know she's a cyclist. We know she cycles a lot until a month ago. So a Brady of like 58 are probably not going to get too upset about, but she is bradycardic, and you knew that without the numbers. That's how good Daisy's eye is. Heidi says Brady too. Okay, is it Brady enough for us to worry about it? Is it the cause of what's going on? And the answer is no, it's not, right? It's around, I think, 58. If I cut off the heart rate, but I think it's around 58, 56, 58. So is there anything, without even like deep diving on this, is there anything that sort of like jumps out at you? Okay, Carrie, nice. Carrie says inverted T. I like that. Carrie, totally agree. Carrie says, I see inverted T, inverted T. Totally, spot on, Carrie. Okay, Sarah says low voltage. I love it, Sarah. She says low voltage. She's right. There it is. There it is. Okay, good. Low QRS. Evelyn says low voltage. Katrina says poor R rate progression, incomplete right bundle, inverted T. Yeah, Katrina's in cardiology. In case you didn't know that, she's amazing. David says P wave is larger than the QRS in V4. The P wave is larger than the QRS in V4. Okay, that's a big deal, right? So if you know that the P wave, right, should be small, the QRS should be big, the T wave should be small, there's problems. So you guys are picking all that up, which I really like. Okay, so let me ask you this big question here. Big question for you. Oh, there's another person in the chat. Let me see what you guys are saying. Dr. GMP in the house. Yes, nice. Okay, there is poor R progression V1 through V4. Now let me ask you guys a question. All right, what are you gonna do with this person, this female? Okay, she's tired, she's short of breath, she's got this low voltage, and maybe it's, let's just say you're working tomorrow, it's New Year's Eve. What are you gonna do with her, right? What are you gonna do? Well, you got a decision to make. We can refer her to cardiology. We can send her to the emergency room, right? Or if we can get an emergent echo. So a lot of folks want echo. I think that's a good idea. How many of you can get echo where you work that same day? I want to know that. How many of you can get echo same day where you are? And you guys are all spot on. I love where you're going with this. Echo is the absolute right thing to do. Melissa says, not me. Chest x-ray. Yeah, chest x-ray might be helpful. What would we be looking for on the chest x-ray? So what would we be specifically looking for? Because it's not a bad idea at all. Evelyn says she can't get a stat echo. I can't either. Even in the ER, right? You'd have to admit the patient most likely to get them an echo. So not a lot of folks can get an emergent echo. Maybe you can do point of care echo. If you have one, like a butterfly, or if you have a point of care in the emergency room. Crystal says trope or PDKGs. Julia says we'd be looking for on the chest x-ray wide mediastinum. Absolutely. Maybe even water bottle heart, enlarged heart. Good, Daisy. BNP and BMP. Yeah, those are good suggestions too. Okay, we got the BNP, it was normal, but the BNP we don't have. So we're thinking CHF. David says, I'm an EMS, I don't have echo at all. 12 leading symptoms. So let's just, as Megan, I like where you're going with this. Let's just go back to the basics, right? Sick female, low voltage. She can't walk across the hall without getting short breath. We know it's probably not a coronary artery issue because her calcium score was normal 4 years ago. It's unlikely, it's still possible, especially with these T-wave inversions, right? And it is still possible with these T-wave inversions that she may have a pulmonary embolus, right? It's possible. And hello, Bernice. Bernice says trope and BNP, okay? Not a bad idea. I'm gonna tell you her tropes were normal. Her tropes are normal, okay? Stress test was normal. What was not normal though, I'll tell you in a second, but what we got to make a decision. Now you guys don't have to say, okay, I don't want to put anybody in the spot, but I want you to put yourself on the spot. I want you to go inside your head and I want you to make a decision. I want you to commit because this patient's going to find you. And the patient actually found 4 providers that sent her home and 4 providers that told her that she was just anxious. And she wasn't just anxious, okay? All right, so pads on patient and hall tail. Julia, like that, that's funny. Okay, Melissa says ACK. I know, right? ACK is right. So Sarah says, super concerned about pericardial effusion. Sarah also works in cardiology. I love it. And so, yeah, Nicole says, whoa. I know, Nicole also in cardiology says, whoa. So guys, this patient, this is one you should worry about. Okay, so this is take home number, I don't know, 3, 4, I don't know, wherever we are. Okay, also Daisy, let me stop because you made a really good comment. I'm glad you said this. Daisy says anxiety goes mostly with PE. Here's the thing. It's possible to have anxiety with PE, but so many times we say, oh, it's just anxiety, right? And we let the patient go. People can be anxious and have something really wrong, right? So it's not anxiety until it's not something else. So Bernice says CTA. Sarah says this is why we don't evaluate family. Yeah, that's very true. Okay, so this patient got an echo. This is a really weird view for those of you who look at echoes a lot. This is actually a view that doesn't exist. This was a cell phone snapshot, okay? So really quickly, I wanna just kind of go through this with you really fast, okay? So tell me, this is the pericardium, okay? Tell me what looks weird about that. Tell me what looks weird about the pericardium, because something looks weird. And even if you don't look at these a lot, that's okay, all right? And PS, the CTA showed no PE, and I love that you guys thought about that. And David is right, it mostly comes with tachy. Totally agree. Julie says there's a lot of space, okay? There's a lot of space right here, right? I totally agree with you guys, totally agree. So let's see, we have a chat. So Kathy says pericardiocentesis. Yeah, that's a possibility. Okay, so there's a lot of fluid here. And yes, Daisy says thickened, Heidi says thickened, Julie says there was a lot of space. So yeah, the pericardium is thickened. It's also very white, which is not normal. So what do you think is going on here? So tell me what you think is going on here, you guys. Type in the chat for me. What do you guys think is going here? Last EKG I saw yesterday was from a patient who said his EKG was due to a panic attack. Yeah, it's always convenient how that works, right? So Doreen says possible tamponade. Doreen, okay, you are onto something. This patient had borderline tamponade physiology. I'll talk about that in a second. But Julie says pericarditis. Good, okay. So this right here is pericarditis. This is a thickened it's a thickened pericardium. It's very white. And yeah, Janice says this is very interesting working in cardiac surgery. Yep, absolutely. And then the other thing that's happening here is there's a lot of space. So what does the black represent, you guys? What is the black representing here? What is the black? And is there supposed to be so much black? What is the black? So tell me in the chat, what is the black? The black is not supposed to be there, right? And so the black is actually fluid, okay? This is fluid. And Julie, yes. And so I like that somebody said pericardiocentesis. That's not a bad idea, right? Hi, Natasha. What's up, girlie? Hey, Jessica says fluid. Yes, right? Okay, so this is fluid. And, all right, and something is happening also over here. Okay, so you don't really see it as much here, but this is the left ventricle. This is the left atrium. This is the right atrium. This is the right ventricle. And in diastole, the right atrium is buckling and the right ventricle is being collapsed in diastole. That is borderline tamponade physiology. Okay, RV looks squished, Carissa says. Yeah, good. Natasha says fluid, Daisy says fluid. Okay, yeah, you're spot on, spot on. Okay, so in in a nutshell, what does she need? Pericardiocentesis is right, but they didn't feel comfortable doing a pericardiocentesis on her because they didn't feel like they had enough fluid. Now they describe this as a moderate circumferential pericardial effusion, moderate, but the inferior vena cava was dilated and collapsed. Okay, that's a sign of impending tamponade. And right, the right atrium does demonstrate some diastolic collapse, as does the RV free wall. So this patient actually got a pericardial window, and the take home on this one, but her EF was still fine, 76, which was good, and her thickness was still fine. And I think they comment on the pericardium later, but interesting fact, okay? What do we know about pericarditis? What do we know about pericarditis? What do you know to be true about pericarditis? Daisy says a chest tube. She did get a chest tube as well and a pericardial window. Hey, Trish, what's going on? Welcome to the B-Day celebration. So what do you know to be true? What do you know to be true about pericarditis? Okay. Well, the EKG will show what? And if you don't know, that's okay. We'll be coming back to it. But her EKG, she had pericarditis on her echo. You saw it with your own eyes. Yes. Samantha and Doreen, our EMS lovelies in here, said global ST elevation, right, with no reciprocal changes. Yeah, easy, right? That's what pericarditis looks like. But if you have pericarditis for a long time, those can normalize, okay? So you don't always have those findings. And yes, okay, so it hurts. Yes, pericarditis, it hurts. PR depression, yes, we're gonna talk about that in a second. Did she have an underlying autoimmune disorder? You know, that's a good thought. They checked her for lupus, rheumatoid, all the things. She did ended up being bit by a tick, and they thought it was caused by a Lyme. But Dr. GNP, good thoughts. Love it. Okay, so yes, pain with breathing. So Bryn, yes, all these are so good, but she didn't have any of those signs of pericarditis that we rely on, but she still had pericarditis. It was just later. So you can't always diagnose it, and it doesn't always have a rub, right? Can't always rely on this. So let me ask you guys a question. Can you see the power in having some of these tools at your disposal? Can you see and get excited about applying some of the things you've learned already into your practice? Because I'm super excited. We've still got 2 more to go, right? So let's talk about number 4 of the night. Tip number 4, okay? I'm stoked. Me too, Melissa Mainville, me too. Okay, so let's talk about the mimics. Now there's a lot of mimics, okay, that look like STEMI, but they're not, okay? Yes, I love it, you guys. Smash some hearts if you're totally loving this. Natasha says, unable to lay down flat without discomfort. Absolutely, absolutely, I love that. Good one, Natasha. Hey, Latasha Bruner, what's up, girly? What's up, Kathy? So there's a lot of mimics. There's a lot of them that look like MI but are not. That's the thing that scares me, okay? I'm worried about calling a STEMI when it's not. And one of the worst things that can happen, right, is if we activate the cath lab and it wasn't even a STEMI. So knowing your mimics is really important to know that too. And Ginger says, I'm a toddler Yoda, but thanks to your 30-day, I'm more comfortable. Oh, Ginger, you're the best. I'm so glad you're here. And you're not a toddler. You've been busting out the right answers. So let's talk about this EKG, okay? Let's talk about it. Let's actually go, let's go to our happy place again. Let's go to where we work, okay? Let's close our eyes. Let's do a little visualization, okay? Picture yourself, you're in your clinic or your urgent care or wherever you work. This patient comes in, they've got chest pain. whoever's working with you, nurse, medical assistant, EMT, anybody who works with you, gives you the EKG tech maybe. And some of you may want to take the chart and pretend you didn't see it and give it to somebody else. How many of you want to do that? Type in the chat, somebody else. Type in the chat, somebody else, if you want to give the EKG to somebody else, right? How many of you want to call David White and ask his opinion? So Melissa says, I want to call somebody else. How many want to call David? How many want to just walk away, right? So let's just say we can't, okay? Let's say we have to make a decision. Let's say we have to make a decision, okay? Super high QRS. Yeah, the QRSs are high. David said, send it to me. I know, right? Send it. Speed dial. Let's get David on speed dial. I know, if only I have David in my pocket, that'd be like a great day. But let's just say we're the only one in our clinic. Okay. Let's just say, even if we have a doc that we're working with or collaborating with, they're in the bathroom. They had some bad Chinese food at lunch. Okay, they're not coming out. And no, you can't slide that EKG under the door for them to read it, because they're going to be pretty happy with you. Okay, so you're stuck. You have to make a decision. Angela says, I'm using a lifeline. Phone a friend, David, right? If only. Okay. But think to yourself, I want you guys to commit. I want you to commit what you would do. I want you to think to yourself, what would you do? Would you call an ambulance? Are you going to call Samantha? Are you going to call David to come, come pick up this patient? Okay. Dr. GMP says compare to previous EKG to see if there's any changes. Could be early repoll, could be STEMI. Yep. Okay. Let's think about all that. Because so I'm going to tell you step 1 of our 5-day next week, right? We're going to be talking about big sick, little sick. Okay. So is this patient big sick or little sick? Well, we have a STEMI accusation from the machine. So we can't do anything until we solve this. Like, our whole 10-step process goes out the window until you say yes or no. You have to say yes or no. You can't weasel out of this. You just have to decide, okay? That's real life. So I'm just gonna really quickly show you what I would do, okay? And you guys don't have to commit, it's okay, but just commit in your brain. I'm gonna show you what I do. I'd actually take one of these. I have it on my badge. I have a little red line, right? I would take this and I would go along my ST segments, but I'm going to just do what other things I could do. I could just use my pen and paper. And what I would do is I would make a straight line on my baseline, and I would look for any ST elevation or any ST depression, because that's how you decide STEMI. Okay. ST elevation or depression. So we're just scanning the whole EKG, ST elevation or depression, right? We're looking for all those, because we got to decide. Okay. And I'll tell you what, the worst phone call to make is when you got to call the emergency room and tell them you're sending a patient, and they're gonna ask you, are we activating the cath lab or not, right? And you got to make a decision, yes or no. That's not really a good one. But basically, in a nutshell, like, this one isn't the greatest one. I'll just tell you, there isn't any right here, and there really isn't any or much right here. Okay. So Jessica says we've got some widespread elevation with no depression. David said there's widespread ST elevation with no reciprocal changes. So if you know anything about STEMI to be true, you know you have to have 2 up and 2 down. Okay, you need to have 2 leads of ST elevation and 2 leads of depression. Do you see any ST depression anywhere? Okay, do you see any ST depression? And the answer is there is no ST depression anywhere. Okay, so if you don't have ST depression, this really can't be an ST elevation MI, because you don't have any reciprocal changes. What you do have is a whole lot of elevation, right? And Melissa says a little hypertrophy and global ST elevation. Okay, so that narrows us back down to our 2 differentials, right? Either benign early repoll or another differential. What is the other differential that this could be? So now that you know that you see this widespread elevation, what else is there? And so yes, you do have some LVH. What else is there? Widespread ST elevation. So you've got benign early repoll, or yes, David, there's a spot X line. Or this could be pericarditis. Okay, good, Daisy, nice. So this patient did indeed have pericarditis, and this was not a STEMI. So literally, knowing these STEMIs can make or break us. We have to be able to ferret this out. We have to, because I'll tell you what would happen. If you call the ambulance, what you may not know is that that ambulance is weaving through traffic. They're going lights and sirens to get there. They're risking their life and everybody's life on the road to get to wherever you are to get this patient. If you call the hospital, what's happening in the background? They're activating, they're moving a patient out of a room who may be really sick because they have to accommodate your patient. And what's also happening is they're calling the cardiologist potentially at 2 a.m. They're calling in the cath lab team, which is the $10,000 to $14,000 activation based on an EKG that was pericarditis. So you can't not know the STEMI Mimics. There's too much writing on it. And that's just a little sad truth, right? That's the scary part. So pericarditis can have low voltage or mimic a STEMI. So pericarditis, it can have low voltage, like we saw that patient right before. But the low voltage was caused by the fluid ginger. And the pericarditis, yes, can mimic a STEMI. Okay, Amanda says, oh, good, yeah, new paramedic here, and this is my fear. Julie, stick with us, sister. We will help you out, okay? Especially David, Samantha, they are some of our EMS gurus, of course, Doreen. So lean on us, okay? Lean on us, Julie. So it's a good question. Where is the isoelectric line? So the isoelectric line in AVR is hard to find, but it's right here, okay? So you're looking from the TP segment, and you're looking at that ST segment. So not really significant anything happening here. There is a couple other clues that this is pericarditis, but I don't want to go into those too much without, I don't want to belabor this too much. We will be seeing this EKG again, PS, by the way, okay? But this wasn't a STEMI. This was STEMI Mimic, and this is like one of 8 mimics. So we need to have these on our radar. Now, the last part that we're going to do of tonight, of the birthday celebration, because I don't know about you, but I am dying to get into these cupcakes. I wish I could have you guys all here with me to have my birthday cupcakes, but we need to know our T-wave bad guys, okay? And this is a passion of David's. David and I, we both love the T-wave so much because there's so much information in them. So there's a long list of things, guys, that can be wrong with the T-waves. They can be hyperacute. Tori, thank you for highlighting number 5. They can be biphasic, which is up and down. They can be inverted. They can be symmetric. There can be something called De Winters. Oh, hey, thank you, Danny. Thank you. And so, yeah, there's a lot of different things. And this is a funny picture I threw in here because I love this picture because I had this EKG blown up really big. And you can kind of see, if you look over here, I didn't put this in here for us to look at, but you can see right here, there's a problem. This T-wave is symmetric and inverted, right? There's T-waves over here that are symmetric and inverted over here, right? Like there's so many things wrong with this EKG, but the truth really is that the T-waves are very important. And David and I always say, if we literally had one wave, it would be the T-wave. Give us just one wave on an EKG and we'll tell you what's going on. So let's talk about the T-waves a little bit, okay? Now, let's talk about this little game I like to play called T-wave jail. Now, T-wave jail is unfortunately a place we put T-waves, and they sometimes shouldn't go to jail. Like, for example, that last EKG went to STEMI jail. He shouldn't have. He was pericarditis, right? Pericarditis, and that was an LAD occlusion too. Yes, David, it was. Well, yeah. David, we can't get anything by you. You can give David an EKG from like a mile away and he knows. But let's talk about these really quickly. Let's name them. Okay, so let's talk about this one really quick. Let's talk about this T-wave. Now, we'll talk about this more on day 1, but in a nutshell, a T-wave should be a little asymmetric, okay? And it should be upright in most leads. So this T-wave is actually normal, okay? So this T-wave is normal. Tell me then, if that T-wave is normal, what looks amiss with this T-wave? Can you describe this T-wave to me? Like what do you guys think? Give me some chat. What is this T-wave? It is too what? It is too what? Okay. It is too tall and too symmetric. Okay, yeah, good, Melissa Mainville. She knows. Okay, so this T-wave is too big. It's too tall. So we'd be concerned about, hyperkalemia potentially. There's a little bit of ST elevation here that could be benign early repolarization as well. But there's two things going on here. We don't like that ST. We don't like the big T. So nice job. Okay. Now, tell me what you think about this T wave. Yeah, Lacey and Daisy both said tall. Okay, what's happening here? How would you describe that one? Okay, it does appear to be a little biphasic, but it's actually it's inverted. And tell me what's happening with this ST segment. So the ST segment is leading into a T wave that is kind of inverted there. Okay, so what would be, how would you describe this, or what would the machine call this? Yeah, Katrina says there's a little downslope. Yep. Little inversion, Bernice. Yep. The machine would call this LV strain pattern. LV strain pattern, okay? Because the ST is kind of sagging down in like a ski slope or a check mark or reverse check mark pattern. And so, yeah, that's kind of like a left ventricular strain. So big ventricles causing the ST and the T wave to repolarize weird. And so the take home on this is that this is not usually ischemia. This is usually just because the left ventricle is so big, okay? And we see that a lot with our high blood pressure patients. Now, there's another T wave that's amiss on here. So this guy doesn't belong in jail. This guy potentially belongs in jail, but this is normal. So he doesn't belong in jail. Now this one is very tall and very peaked. So I would be worried about hyperkalemia with this one. We all know that. But let me ask you a concept question on this one really quick. Okay, this one doesn't belong in jail, potentially. I don't think he does. But how would you describe this T wave? How would you describe? And yeah, so Melissa Mainville, good job, girly. How would you describe this T wave here? Okay, so Daisy says potentially hyperacute. I agree on that last one. More narrow, exactly, Lacey, which makes it more suspicious of hyper K. But this one here is a little bit flattened. Yeah, Dr. GMP. So it's flatter. And so potentially this patient could have hyperokalemia. So if this is hyper, this is hypo, and that makes total sense when we think about that, right? Like total sense. So not every T wave belongs in jail that gets put in jail is the moral of the story. And you need to know your shapes of your T waves. So which one are you most excited about that we've learned tonight? So type in the chat, which one are you most excited about? Which one of the findings, which one of the tips tonight have you been most excited about? So type that in the chat for me. We are nearing the end of our, I kept it to half an hour. I'm super excited. So type in the chat what you're most excited about. The mimics, yes. Oh my gosh, the intervals, exactly, Melissa. I totally agree. So yeah, there's a lot of really fun things we learned tonight. So let's just recap a couple of them. We learned about the T waves that are how they should be. We learned about some STEMI mimic. We learned about the intervals, what is normal, and we learned a lot about voltage. So literally, we also learned about Brugada. And Tori says, everything, can't wait for next week. I know, me too, girl, me too. Mimics for the win, Lacey says. Yeah, drawing the line through, totally agree. So if you guys think this is great, you're gonna love the 5-day next week. But there's the bad news is that even though we covered a lot of ground, there's still a lot more for us to learn. So we do have some time together next week. I'm so excited about that. But really, when you think about the things that are scary and dangerous, this is a list of some things that I'm kind of worried about just in everyday, right? Learning when to call a STEMI or not. Kathy says mimics and voltage. Z, what's up, Z? Yes, Natasha, you're awesome. So these are a list of things that we don't want to miss. We talked a little bit about mimics. We talked a little bit about hyper K, but things that the machine says is normal, but really aren't. Okay, like for example, that Brugada, the machine didn't call it. So there's a lot of things that we kind of feel like we're climbing uphill to learn, so many things to learn, but really when you focus it down, you really need to just stick to the high risk things. Those are the things we need to worry about first before we worry about the little things, okay? So the good news is that you have me. You also have a bunch of our coaches that are be coming along with us next week. I got Coach David, Coach Michelle, Coach Megan will be popping in, Coach Gary will be popping in. There's a lot of good people that'll be coming with us. So, but you don't have to walk uphill alone anymore because you now have a tribe, and that tribe is us. And we're so happy you're here. But let's get down to the prize tonight that we're going to give away. Okay, we are going to give away a prize tonight, 2 prizes actually. And so this is where we're going to be in it to win it. Yes, Katrina, happy birthday. Thank you so much. This has been an amazing birthday spending it with you guys. No other place I'd rather be. Thank you, Yolanda. So let's get into the prizes. And also, by the way, I want you to type in which cupcake I should eat. Should I eat the chocolate or the vanilla? So type in the chat for me, chocolate or vanilla, and then I'll eat it at the very end. But let me talk about the workshop that we're giving away the virtual ticket for tonight. I want to tell you a little bit about that. Chocolate. Okay, everybody's, oh, both. Okay, both. Okay. So there's a live workshop we're doing. We're doing two in California. Okay. We're doing one in Monterey, May 22nd, and one in March 6th. Gigi says chocolate. Chocolate. Okay, I'm getting a lot of chocolate votes. Okay, now maybe I'm not so sure. I'll have to tally it all up. But we're giving away a free ticket to the virtual one in Monterey because it's going to be professionally live streamed. So the March one, I'll just tell you about that really quick. We have 28 spots left in this one. It's filling up pretty quick, but we are doing one in March. This one is live only, no virtual option. And we're going to go through basic arrhythmias, breakout sessions with me and Coach Michelle. We're going to do lots of hands-on and breakout sessions. This is going to be in Culver City. You get 8 hours of CE. And this one is 147, March 6th in Culver City. Really good, easy in and out airport access. If you want to meet me and Coach Michelle next year, this is the good way to do it. It's going to be a very intimate setting, lots of hands-on with you guys. And there is still, I think, 28 tickets left to this one. So that's one option for you. If you are, yes, the link, it's on conqueringcardiology.com. Melissa Torres. Oh, that's right. You live down there. I might get to meet you. That would be awesome. So just go to conqueringcardiology.com. At the very bottom, there's a link to purchase the leftover spots. And then the one we're giving away, the virtual ticket, is going to have a bunch of coaches. We're going to have not only me and Coach Michelle, but we're going to have Coach Sean flying in and also Coach Megan. And we're doing breakout sessions with all the coaches. Okay. We're going to have a catered lunch. We're actually doing it like a few steps from the ocean, which is really going to be great. So on the break, if you want to dip your toes in the ocean, should you want to on May 22nd, that's fine, right? And we're going to start with basic arrhythmias, basic 12 lead. And then we're going to do a hands-on workshop, and we're going to have the coaches compete. And you'll get to watch this live virtually, okay? We're going to have the coaches compete on something called 3 slides, 3 questions. And you'll be voting for who does the best, and whoever does the best will get a prize. So that'll be super fun. And this will all be live streamed. So even the work breakouts will be live streamed as well. So one lucky winner is going to win a ticket. So guys, if you want to win the ticket, the hashtag to put in is hashtag Monterey. Hashtag Monterey, because that's where we're going to be in my hometown. You'll be going out to dinner with me afterwards if you come live. There's only, I think, 19 spots left in this one. So Patty says hashtag Monterey. Melissa, yes. Kathy, good. And so, yeah, that's the skinny. So I'll be drawing live for anybody who says hashtag Monterey, and I'll be coming back on with husband John to announce, and I see a lot of people on Zoom, to announce the winner. But really quickly, let's take a second and celebrate my birthday. And I'm going to eat a little bit of this cupcake, and I'm saying cheers to you, all of you, for joining me tonight. I really have appreciated spending time with you. I'm going to eat the chocolate one first because it's my favorite, and I'll jump back on and draw the ticket. But I'm looking forward to meeting some of you in person that want to come live to this. There's going to be very good interaction. Yay for the chocolate one. P.S. These are gluten-free. Okay. Yep. I'll finish these later. But thanks for spending my birthday with me. And I'll see you back in a few minutes to do the drawing. If you don't win a virtual ticket, or you want to come live, you can go to conqueringcardiology.com and you can enter it to be in it to win it. Michelle Barkley says, happy birthday, Michelle. I'm so excited you're here, girly. Thank you guys all for hopping on. I'm going to jump off, draw your names. It's been a pleasure to hang out with you guys tonight. And Happy New Year. I'll be seeing you in a few minutes, but also just a quick reminder, next week, we're going to be doing our 5-day EKG challenge next week. And that's going to be amazing. You can join on Zoom. You can join on Facebook, either way. Thank you, Dr. GMP. Appreciate it, girly. And yay for the 5-day. So that's exciting. So I'll see you guys soon. And bye for now.